All right, so good evening, everybody, and welcome to the third in a series of 6 discussion forums put on by Thorn Harbour Health, where we're really looking at and doing a deep dive into HIV and research, and looking at how researchers can work better with communities of people affected by or at risk of acquiring HIV or people living with HIV, and how we can do things better in the future. So we reflect on the past and the lessons learned over some 3 or more decades, 4 decades now of doing research on HIV, and we look to the future and how we're going to do things different. But I wanted to start, of course, by doing an acknowledgement of the traditional owners on the lands on which everybody is joining us from this evening. I'm in my office of the Burnett Institute in Melbourne. So I am on the lands of the Boomerang and Wurundjeri people of the Kulin Nations, and I acknowledge their elders past, present and emerging, and that this land was never ceded. And I also acknowledge the traditional owners of the lands on where you may be around Australia, or potentially even dialing in from or watching from overseas, where you have traditional owners of your lands as well. So good evening, everybody, and welcome. For those who haven't joined us in the last 2 of these series discussions, it's a panel of great minds and experts. And tonight, looking at the lineup, we're in for a treat of people who are very well experienced in the field of HIV research here in Australia in different jurisdictions, and we stand to learn a lot. We're really looking at the past in terms of how HIV research has been done and what it's taught us and where we've got to today. We're looking at what some of these researchers are currently working on today. And then we're going to ask them questions about where they think our focus should be in the future. Considering HIV notifications in Australia, thankfully, are coming down due to all the hard work that has been going on for decades. But that leaves us at the pointy end of trying to answer the questions that are going to help us get right to the end of stopping the transmission of HIV in this country and making sure that people living with HIV have the best quality of life we could expect. So what I'll do, everybody, is format this as a interactive discussion with the panel. You will see, those of you who are joining us on a Zoom forum, that there is a Q&A function down the bottom of your screen. If you have any questions either directed to the panel or directed to a specific speaker on the panel tonight, you can type your question at any point in there, and our panelists will either try and answer that verbally for you or will type a response for you in there. So please, this is an interactive participatory process. Please use that Q&A function, not the chat function down the bottom, and we will remind you of that as we go forth. You didn't come here to listen to me waffle on the whole evening. You came to learn pearls of wisdom from our expert panel. So I'm going to introduce the first person I'm going to ask a question to this evening. Well, I should introduce myself first. I'm Chad Hughes. I work at the Burnett Institute. I'm the head of international development programs here. So I look after our teams working abroad in Papua New Guinea, Myanmar, and elsewhere on HIV, as well as other pathogens, and support our teams that embed research into those activities. Yeah, and thanks to Thorn Harbour Health for hosting these forums, and tonight, Thorn Harbour Health, an organisation that I was previously the president of for a number of years. So good to be back engaging with them. Anyway, Professor Kit Fairley, welcome. For those who haven't met Kit, Professor Fairley is the director of Melbourne Sexual Health Centre and is Professor of Public Health at Monash University. The main focus of his work relates to designing clinical and public health interventions to improve the control and management of HIV and STIs. Kit, we'll let you show your face so everybody can see you. There you are.
I'm sorry, I wasn't sure whether I was supposed to leave my ugly face out of it, but anyway.
Oh, it's good to see you.
So thank you very much indeed. It's great to come and talk about this. It does mean I've got to reflect back over a really rather long period of time. So you asked me what...
Sure. So what I want is for you to consider, what do you consider to be the milestones in HIV prevention research that have led to significant change over the past 30 years? It's a big question. Let's hear from you.
In 4 minutes. Okay, here we go. I'm starting now. So I think there were probably 4 bits. There was the very beginning, the dark days of the late 1980s, and when really the question was, how's this transmitted? I don't think anyone needed any encouragement to prevent getting it. It was really a matter of how do we prevent it from people from getting it? What is safe? What's not safe? How do you increase access to condoms and stuff like that? And having had a false positive HIV test when I had a needle stick in about 1984, I remember vividly what it involved. Then after this long, depressing, horrible time, we sort of got this light on the horizons of the mid-1990s and early 2000s, where treatment suddenly let people live much, much longer lives, but the treatment itself was pretty crap. And so there was a lot of discussion, and the questions at that time in my mind were, how do we encourage prevention or the rest of it? Do we tell people how unpleasant these treatments are to take, or don't we? Because that might label people, might adversely affect people who have HIV at the time. I remember tensions with Colin Petruni at the time. He's a much more experienced individual at communicating stuff, but I remember he ticked me off a few times, and David Menadue ticked me off a few times as well when I was learning certain aspects that I hadn't really understood very well. So there was the dark days, then there was the first treatments that worked well, but they were pretty yuck to take. Then there was a fabulous time where these new treatments came, they had no side effects, and the data came in about treatment as prevention. So it was a matter of diagnosing as many people as we could, treating as many people as we could, getting them onto adherence. So all the questions that relate, the research questions, were all about those things. How do we test people more, treat them more, et cetera, et cetera. And then we entered this really wonderful period now where we have 100% essentially protection. So the question is, how do you get as many people as possible on PrEP? Should it be on demand? Should it be continuous? If they're not taking that, how you encourage them to use condoms, or prevent anyone in the middle? That's no PrEP or no condoms. How can health services work now to prevent HIV? It used to be an individual choice. Now it was really about a health service or health services community working optimally to prevent it. And the good data in the US that shows that if you have good health service, you get much less HIV transmission than if you don't. So it's not an individual choice, it's about government decisions. And so I suppose those are the 4 periods that I remember, and I've become less and less naive over the last 20 years, although I still think I have a lot to learn.
Thanks, Kit. It's good to look back at that history and to see, as you say, that we end up in a place that's much better than where we were early on. So much progress, but still things to be done today and in the future. Edwina, Associate Professor Edwina Wright, welcome.
Hello there.
Let's see your smiling face.
I think you have to take my video away. You have to.
Sure. I'm sure someone will sort that out for us, so we'll be able to see you. But for those of you who haven't had the privilege of meeting Edwina Wright, she's an infectious diseases physician and clinical researcher at the Alfred Hospital, Central Clinical School, Monash University. She has honorary affiliations with the Burnett Institute and the Peter Doherty Institute. Dr. Wright began her HIV clinical research career in 1993 at Fairfield Hospital. Her HIV research expertise lies in the areas of the benefits of early treatment, HIV prevention, notably HIV pre-exposure prophylaxis, known as PrEP, HIV cure, and HIV neurological disorders. Dr. Wright is a past president of ASHM, and she is the chair of ASHM's COVID-19 task force. Wow, there you go.
I'm sorry, I should have made that much slimmer. I didn't realize how that was all going to come out. So
it's perfect. It highlights the expertise you bring to the question I'm about to ask you.
Yeah, thank you.
So my question is, what do you think have been significant barriers to people adopting HIV prevention measures?
Yeah, thanks. I really enjoyed thinking about this question. So thank you very much for the opportunity and for inviting me here. And I look back, and I would like to invite us to step back quite some time ago and think about what really was the failure of a kind of a collective will, if you like, to drive forward the science of biomedical science of HIV prevention, get the products registered in a rapid sense, make sure that there were excellent and fair intellectual property rights assigned to the products so that they could be produced in countries, and to sort of broadly advertise to the whole community, especially in the 80s and the 90s when HIV was sort of like the current COVID. So I'm completely guilty. It's absolutely mea culpa of being very much swept up in the medicine and the care of people who are dying from HIV, because it was tremendously confronting. Just as remember all the images, or still the images of people dying from COVID now. How could you even think about prevention, for goodness sake? Let's keep these people alive. And I used to think, why are they talking about prevention so much? So many people are dying. I was so wrong with that clinician's viewpoint. But there were signs very early on that HIV could be prevented. So when Tom Quinn published in 2000 in the New England Journal of Medicine, a cohort of couples, heterosexual couples, he followed them forward, did their plasma viral loads over a long period of time. None of them was on treatment. But he reported 21 years ago that people, the positive person in that heterosexual dyad, if their viral load was less than 1,500 copies per mil, they weren't transmitting. So there was already a huge signal then and there that there must be something to do, to do with that. And the Swiss statement came out, and I think lots of us are outraged there wasn't enough science, and there wasn't. But why wasn't the science, immediately pivoted and money spent, not taken away from other research endeavors on how to prolong people's lives with HIV, but why wasn't there a huge community, push towards that? And a corollary, I think, also is just think about the wonderful work that Bob Grant did. He published IPREX in 2010. That was 11 years ago. We only got it PrEP registered and a PBS PBAC subsidized, in 2018. It finally got through that hurdle. So I think that that's a big thing. And I really would like to say that a big lesson for us to learn, and I think it's been seen with COVID, is that very early on with a new pandemic, with a new virion or bacteria, don't forget about prevention. Put that straight up as front leader, both horses in the race, in terms of trying to ultimately prevent it from having an ongoing energy. Stigma, of course, is just an ongoing issue around prevention. But also, I think risk perception is probably one of the gnarliest obstacles. The individualization of a person and how they experience and see themselves in the world. The way we see ourselves on a day-to-day basis is, of course, so different from how other people see us and other health economists see us, or health professionals, etc. So I think that risk perception is probably, in fact, a really big thing. So yeah, thanks for that opportunity, Chad.
Well, just listening to you, thinking, when you put it in the chronology of how long ago it was that the first evidence of pre-exposure prophylaxis and also treatment as prevention, which now are mainstays of our evidence base and our responses and our policies and our interventions, that was 11 years ago, and even earlier, 20 years ago, for the idea that undetectable would be untransmittable. It's quite phenomenal, the number of years there that have passed before we get to the point where there's still so much more work to do, knowing, for example, with PrEP, not so much in Australia, but in other countries in our region, it's just still not even available for people. So still work to go there. Thanks, Edwina. All right, our next speaker is Dr. Jean Ellard. Jean is a social scientist with 20 years of experience working in the field of HIV. She led the qualitative arm of the seroconversion study from 2001 to 2006. She is an investigator on the PREPARE study and worked on the qualitative arm of the PrEP study. She has extensive experience spanning policy, research, and capacity building. Welcome.
Welcome to that's a big ask. Thank you, Chad, and I've also been kind of looking forward to the question I'm going to be put to me. And
good. And that question is, there are particular issues faced by a variety of marginalised communities. For example, overseas born people, closeted gay men, in relation to HIV prevention here in Australia. What are the most pressing issues that need to be understood to make progress?
Yeah, so I guess I'll reflect on it in two ways. I think we probably, in a really broad sense for public health, the pressing issue is, how we increase prevention coverage or engagement in treatment and care for those communities. So I guess I want to kind of, as a social scientist, look at one of the real strengths, I think, of the response here in Australia, but in other parts of the world, was a really, in the past, a really strong investment in interdisciplinary research, and in that mix was critical social science. And reflecting on the way in which I think, again, in the absence of, even in periods where there was an absence of good treatments or anywhere near as many prevention tools, I think one of the real strengths of critical social science was it drilled down into the everyday lives of, in particular, gay men's lives. It was able to look at the way they were interpreting science and adopting it into their everyday practices. And I'm thinking there famously of negotiated safety, but also other risk reduction strategies. Again, from my own early beginnings in this sector, I worked on a study looking at looking at the experiences of newly diagnosed men, and that work was really about fleshing out the context of we knew what the biological sort of mechanisms of transmission were, but that kind of critical social science allowed us to really understand the context. And so I say all that because I think in thinking about, for example, overseas born men, in the present, I don't think there is the same kind of investment in critical social science. And I think that's an issue because we actually don't, there's been some great public health research that tells us who these marginalised communities are, but we're really lacking a sense of what the priorities of those different communities are, how they might prioritise sex or health or perceive of HIV prevention. I think we have, I sort of struggle a bit with that. We do get some qualitative work done, but qualitative work isn't in and of itself critical social science. So I think sometimes we're a bit stuck with descriptions and are kind of taken for granted as if an interview or something someone says is a kind of fact. And I think, again, what critical social science does or has been able to do is it's as much about getting into the silences, the things that are not said, the implicit within data, and that's really kind of crucial. So I guess what I think moving forward we need is to reinvest in critical social science. And I think this idea comes from Barry Adam, who's a Canadian social scientist. You know, he recently in an article reminded that we need to actually follow the logic of the people we're trying to understand. We need to look in a thick and rich way at their everyday lives. I'll stop there.
That's perfect. Thanks. I recall something that struck me at the last one of these forums we had when we did talk about overseas born, people who are residing in Australia either temporarily or more permanently, in the sense that, there is so much more research and learnings to be done there. And it's almost like we go, okay, there are Australian born people and then people who are born overseas, as if they're one group, but it's a myriad complexity of thousands of different cultural groups and languages and
yet we use culture quite broad. We use culture as if that's an answer rather than just something that you have to bring a specificity to for each of those different.
Exactly. Yeah, so much more work. I'm going to ask somebody else who's joining us tonight about the same groups of people, I should say, after my caveats in there, and that's Associate Professor Jason Ong. Welcome, Jason. How are you?
Good. It's great to be here, Chad.
So Jason is a sexual health physician based at the Melbourne Sexual Health Centre. His research focuses on ending HIV transmission in Australia and beyond. He's given a very short bio there, but those of us who know Jason knows he dips his fingers into a lot more parts of the HIV sector in being on various committees and the like than just that. So a wealth of experience beyond just that work you have there at the Melbourne Sexual Health Centre. My question for you, Jason, is that, recently there has been that increase in the proportion of HIV notifications that are among overseas born men who have sex with men here in Australia. In your opinion, what are the drivers for the increases in these populations?
Yep, thanks for that. So in that statistic, there's actually some really great news and some really bad news. And I think the really great news is that the HIV rates amongst the Australian-born gay, bisexual, and others men who have sex with men are actually going down, and therefore causing the proportion to rise in the other group. And I think the other panel members had already spoken about a few reasons why that's the case. But unfortunately, the bad news to that statistic is that actually, with the exception of 2020 and this year, because we kind of all these overseas people are stuck outside of Australia, there's actually been a plateauing or rising numbers of HIV amongst the overseas born. And specifically in Victoria, actually in 2019, so this is pre-COVID times, it was the first time ever that the numbers of new HIV infections were higher in the overseas born compared to the Australian born. And so that trend, again, was because of COVID that was kind of buckled a bit. But I think that the reason why there's this increase in HIV amongst these overseas born men who have sex with men is the health inequities that has been so clearly kind of unveiled because of COVID, and specifically their access to really effective prevention technologies. So things like PrEP, and you also mentioned U equals U, so undetectable equals untransmittable. And so because these overseas men are not able to access these drugs very easily, we see this discrepancy in the HIV notifications. And it's quite scary, actually, in terms of, I was reviewing the stats of how many people who are undiagnosed. So if you're an Australian-born man who sex with men, you're probably about 5% of Australian-born are not diagnosed. But if you're overseas-born, it's about 15%. And depending on which countries you come from, it could be higher as well. So, and we all know that getting people onto treatment will also mean that we have less infections. Beyond just that pure health inequities of access to these kind of technologies, there's a complex web or layers of factors specifically for overseas born men. So I've got a few kind of factors here. So firstly, we notice still a lot of fear of testing, and that's about stigma and discrimination. I know that we all want to stamp out stigma, but unfortunately these groups seems quite accentuated. There's still low knowledge about HIV and the ways to prevent it, particularly those who are newly arrived from countries where same-sex behaviors are criminalized or frowned upon, or where sex is kind of a taboo topic and they have really poor sex education. So we do see this cohorts of people coming through with kind of low knowledge. And the other thing, many of my patients say that, you know, HIV is a completely low priority when they first arrive in Australia. I mean, when they arrive in a new country, it's about accommodation, it's about finding a job, about just finding your feet in this new land. So they don't really think about HIV prevention, and that's very low on their list. And even if they are knowledgeable and want to access the services, there are a lot of structural barriers. So we know that this group of overseas men, they have poor access to PrEP because it's not subsidized if they don't have Medicare yet. And another kind of newish issue that I'm looking at more is the workforce side as well. So we're starting to see a lot of people coming through that say, I want to access PrEP, but my GP has no idea about PrEP, or they don't feel comfortable to talk to their GPs. So now that PrEP is PBS listed, which means that every doctor can prescribe PrEP, I think we need to pay more attention to making sure that our GPs are able to prescribe these medications as well. That's it. Thanks.
Yeah, great answer, Jason. And drawing upon your experience, I see in the chat we had a question specifically around, you know, when we're working with these communities of people from abroad, do the researchers themselves have to come from within those communities or not? No. I think, Jean, you wanted to respond to that, or you may have already in the chat, but happy for you to jump in. And
I think I tried to respond in the chat, but accidentally pushed the responding person. I think the short answer, absolutely yes. I think we need two things. I think we need researchers from those communities. I think we may also need to engage with researchers from different fields who may already have really long established working relations with the different marginalised communities we're thinking about, because it does take time to, and I'm really reminded again going into the past that that's very much, I think, at least in the kind of social science field that I work in, but I imagine actually across all the disciplines. You know, I know that really there were two things that happened. I think gay communities approached some researchers in the social science fields, and I'm thinking of people like Sue Kippax and Bob Connell, Raywin Connell now, who had expertise in doing kind of behavioural and social research. But there were also people like Gary Dowsett who were also members of affected communities, and there's been quite a strong tradition of particularly in the social research field, of people from those affected communities. So long answer to now I've gone into a long answer to that question, but yeah.
No, and I agree with you. I mean, as somebody who works in development in communities abroad that are not my community, I, for decades in this work, both here domestically and abroad, see that and agree with you that there is a role for people from the communities that are being worked with and who are, I guess, the intended beneficiaries of the research or the work or the downstream translation of that research into practice. And it's essential that they are involved from the beginning, from the origin of the idea through to the end. And it doesn't necessarily have to be just people from those communities. And I agree, people have solid skill sets and professional skills to bring to the table and can do that in a meaningful partnership with those people, and that's probably the best approach.
Yeah.
I'm going to introduce our final panelists for the night. Last but not least is Associate Professor Graham Brown. How are you, Graham?
I'm well, Chad. How are you?
Good, thank you. So for those who haven't met Graham is a Research and Evaluation Director at the Centre for Social Impact. Graham has been working in HIV health promotion, research and evaluation for over 25 years with a focus on the role of peer and community-led programs, which kind of segues from what we were just talking about, doesn't it?
It does actually. I was actually just reflecting on what Jeannie was saying, and I think it would be about 20 years ago. Let's just say I started in the community sector and complained enough about researchers and how what was happening just simply wasn't relevant enough for what I was doing in the community sector. This is 20 years ago. It's certainly not like that now. But complained enough that most of my colleagues said, why don't you just go and do it? So it was, basically as a gay man living with HIV, I got angry enough with what was happening that I decided to try and go and do it myself. I then discovered how hard it was, but that's a different story.
Well, there you go, the pure example of somebody who comes from the community but also has the requisite skills, and knowing you and your work, outstanding skills as well. So I have a question for you, Graham. Your social research and health promotion experience has dealt with a variety of HIV prevention initiatives over the years. After almost 4 decades of HIV prevention information and education, are you confident that a baseline HIV awareness threshold exists in the community?
It's an interesting question. There's quite a lot in that. So it's quite an interesting question. And I would put it to that I'm not sure awareness is the issue. We've got a lot of strong evidence that there's certainly a lot of broad awareness around HIV, both helpful and unhelpful, both helpful and stigmatizing awareness and understandings. And the research is pretty clear around that. And I think certainly from a lot of the experience that people have. I suppose baseline awareness is one thing, but awareness by itself, we know, rarely leads to change. And humans are just a bit too complex for that. The other challenge with it, with a sense of baseline HIV awareness, is, as the other speakers have been saying, things will have and will continue to change so rapidly that what was HIV awareness 5 years ago, 10 years ago, just doesn't really cut living in a community affected by HIV now. What I'd say is what we actually need is sort of more baseline aspects around a broad understanding of what HIV actually means for someone in Australia today, what treatment means, what U=U means, what PrEP actually means, an awareness of confidence to actually negotiate treatment options, prevention and treatment options with sexual partners, a confidence to call out stigma when it's occurring and actually act on it, and what all of those things actually mean across the different communities that even referring to before with, people from overseas, born overseas, or different cultural backgrounds and so on. An awareness around mobilisation of a community to actually achieve equitable access. So I think they're the kind of, I suppose, thresholds that we should actually be looking for. We've got a really strong foundation of 4 decades, but certainly there's a lot of work to go there. I actually think probably the best health promotion isn't about awareness. The best health promotion about HIV prevention, living with HIV, challenging stigma, is actually about working within and alongside communities that are already adapting far more quickly than research, health promotion, or clinical services will achieve. So it's actually working with them and helping communities adapt in ways that are going to be enabling and health promoting than necessarily assuming we're going to have all the answers. And that's happened throughout the entire epidemic. Even Jeannie was saying before, if you go back to negotiated safety back in the 90s through to PrEP and U=U today, all of the actions around that PrEP was already happening in different ways in different parts of the community before all the evidence came through. U=U was already happening in different parts of the community. The problem we have is the knowledge is not consistent across affected communities and across general community.
There's still a lot of work there in I guess, health education and getting those messages out there to the
and I think the key thing there is like some of that's about campaigns, but a lot of it's actually about I suppose a lot of the things that I often think about is when we're talking about health promotion is when we talk about, what do we need to do to increase knowledge and so forth. It works best when the we we're talking about is actually the communities we're talking about, and it's the same people. That's when we start to get real shifts.
Thanks, Graham. I'm going to ask all of our panelists to turn their videos back on even though they may not want to, just to remind our participants, both on Zoom and on Facebook Live, the expertise that you have before you this evening, and that it's a Q&A style discussion. So fire away with the questions. If I look at the list of participants, I know pretty much who most of you are, and I know that you're very engaged and intelligent people. So I'm surprised some of you are being quiet so far. So looking for those questions to come firing in. But Kit, I've got another question for you. You have seen innumerable shifts in HIV prevention over the course of your practice. What research question, in your opinion, will lead to the next significant change? It's a hard question to answer, but
yeah, I think the key question is, how do we, so given HIV and to a similar degree, STI prevention has got so much to do with government decisions about good policies and not about individual choices. The question is, how do you influence governments to make intelligent, sensible, long-term, analytically informed decisions rather than respond to some sort of acute event that's largely irrelevant? So I think that's how do you influence governments to fund PrEP, educate all the rest, educate their practitioners about that? I think that's the key question. How do you influence government? And I'm not good at that.
Sure. Thanks, Kit. There's an interesting question from somebody in the chat. And I'm going to direct this to you first, Edwina, because it's kind of along the lines of what I was going to ask you anyway. So I can link the two together. The question from our attendee is, with everything we know in prevention research, should we now just focus on cure research? So part of that question is about, I guess, limited funds, we can't focus on everything. Should we be prioritising the cure research? But the other part of that question is, are there any gaps in our knowledge on HIV prevention that we should be focusing on as well?
Okay, thank you. Well, this is a little bit heretical to say this, but you can argue, and I have said this once before in public, that cure research is actually just an extremely long way round of HIV prevention. I mean, it is a form of HIV prevention for the long haul. So I don't believe that there is, that we should have the mindset where we say we only have limited funding. Coming back to Kit's point, we need to elect and choose people and governments that will make health and education chief, and sort of a whole lot of other social justice issues, the chief priorities for the population. So I just refuse to engage in that idea that should we cut this and then put money in that. I just will not resile from that. And of course, cure research is very important for many reasons. Least of all, again, perhaps another future retrovirus that comes our way, which may be even, who knows, airborne or, completely different, has a whole new twist on it, but has a similar way of remaining incurable. I think just, and forgive me, these answers are a little bit off the cuff, but in terms of gaps in understanding of HIV prevention, I think that we have, especially in high-income societies, we feel that we are impervious to needing a good scrutinization by anthropologists. We think you only go to the Tobin, that it was only Margaret Mead, and you go out to societies where people live in the bush, and that's the only anthropology you need to do. We're above that. But actually, I think that much greater attitudinal understanding of people's lives, the daily aspects, the quotidian aspects of people's lives. I'm talking about a 26-year-old bisexual tradie who's just finishing his plumber's course. What's the anthropology of that guy? What do I know about that? And have I designed my study with that person in mind? And then within that, where does sex and injecting drug use fit in according to all the other competing factors in their lives? Because when we design a trial, we're very invested in it. And I'm talking about clinical trials. I'm basically probably talking about PrEP here, let's say. But even a cure trial, for example, or a new antiretroviral trial, we have blinkers on. We think that what we're doing is the most important thing that anyone is doing at all on the planet at that moment, and hence we go in with this focus with the patient as the subject for our, the patient is an object to us. We want them in this endeavor that we think is so important. So we don't want to look at the person as a whole, because that's not our objective. Our objective is to get a result with a good p-value. Okay, and I'm being kind of a little cynical here. I don't mean to, but I'm trying to drive home the point that we just don't platform the people and the small details of their lives enough to our peril. And that was borne out very clearly in the two studies, the Voice trial and the FemPrep trials, the two PrEP trials of women in Africa, which they just really failed to understand what these women's lives were like. And that brings me to the next point, which is understanding the dynamics around power in research. And if you're going to a society, to a group of people whom you believe will benefit from a new intervention for HIV prevention, they have a lot of other competing issues in their lives, and you're essentially asking them to change something which was probably going fairly smoothly, but you're a doctor or you're a researcher and you have a lot more power than they do, basically, at the end of the day. So what do you understand about what's going to happen as a result of that power differential? And that comes back to the discussions earlier on tonight, which is what role do people in the community, people we're trying to work with, play in the design and the running of our trials? And I know that I sort of bridle a little bit that we all have to do something incredible like what Graham did, go and actually do the study and become that very person, and that discipline synthesis of carving out a career formally. But I think we need to be a little bit more creative about bringing in people much more actively involved in the clinical trials who are not necessarily in any way formally trained. And I know research is underway like this in different fora, where you bring in peer workers to undertake research and interviews. So again, coming back to being the sort of the snobbery of the high income countries, it was only those kind of African countries which needed peer navigators to help them talk about treatment and things like that. We didn't need that because we had nice clean clinics where you could speak person to person alone in a room. But actually, turns out we probably really need what's the role, what's the gap in us understanding the role of peer navigators in clinical research. So I don't think we know that. I don't think we understand power differentials enough and understand people's lives enough. I don't think we understand yet how effective, especially for prevention trials, it might be if we go to the patient instead of dragging them across town to our clinical trial centre. And our COVID colleagues, people like our colleague in our department, James McMahon, and many others around the world have really, begun to pioneer this in-home or in situ. You go to them. Why not we go to them? Why do they always have to come back to us? Again, that's the reflection of power. And finally, I think, one gap which we could address, and this yet again comes back to the anthropology of a person's life, is how much better, how much more effective would an intervention be if we married it up with other health needs? It's kind of a no-brainer, really, but like you can now you can combine the poly pill of a prevention. The idea of sort of having that you don't make the prevention the primary aspect, you're also combining it with a hypertension drug or other things. So we just infiltrate across other health disciplines and find out, would people like to have a hypertension tablet with their PrEP tablet? Would they like to be combined? What do we know at all about that? So I think there's some of the things that come to mind with that question. Thanks, Chad.
Well, a lot of food for thought there, Leanne. Thank you. I think that for me, you kind of start to hit the nail on the head around these forums, which is that question of who's not at the table, which people in the sort of breadth of communities and people who aren't even linked to communities that you would associate HIV with, who are being impacted by HIV in Australia, are not there at the table when we're doing research. So we're not getting that data or the answers from those particular groups, be that your 26-year-old bisexual tradie or somebody who's, Jason was referring to earlier, comes into his clinic and has recently arrived in Australia to study or work and has bigger issues to, deal with than thinking about HIV. Just needs to figure out how to get affordable housing and navigate their way through a new culture. So I'm going to ponder on that a little bit and jump back to you, Jeannie, and sort of think, how do we engender that sense of participation in those hard to reach populations, whoever they are, those people who are not there? When you do HIV research, clinical, social, whatever, and you think, okay, let's get participants, I imagine people who sign up for those things are the ones going to the high caseload clinics, and they're often your cisgendered white gay men who've been living with HIV for 5, 10, 20 years and are more comfortable talking about it, more middle, upper class. They're not necessarily representative of the face of HIV in Australia today. What do you think? How do we get that?
Yeah, well, I think, well, yeah. So pondering this question, I thought about this, and I will just, well, if I take the example of overseas-born gay men, they're much closer than we think. If we think about, some of the particularly work I think that Philip Keane has done on sort of using postcode data in Sydney, really actually shows that, in fact, more overseas-born men are likely to live in the postcodes that have more than 20% of gay men living in those communities. Of those overseas-born men that live in those postcodes, their sort of patterns of HIV testing and PrEP use are not really different from those of their Australian-born, whatever, these, neighbours. So I think that's one thing to sort of remember, that they may not be as far away as we think they are, but they may also be a starting point for. So if I take overseas born men, they may be some people that it may be easier for research to meet, to connect with. They are often the people from those communities who are doing the gay community periodic survey. So they may be a starting point, and kind of picking up a bit again on Edwina's comment, that they might be the insiders, that they might be our insiders that we can connect with. I'm not saying it's easy, but they probably are coming into our clinics, our AIDS councils. So they may be that first point of contact to get at the kind of the sort of everyday lives of those people, finding out exactly, yes, is HIV much of a priority? What do they know about, presumably they do have connections outside, to other parts of their community. So I think that is, possibly a real starting point, but it's also to be willing to, again, picking up on that idea of, we need to be able to really drill down into, and really try to understand what people's lives look like, and bring them to the table to, And we know how to do it. We've done it in the past. We just might need some different players to come into this now.
Yeah, exactly. And I guess part of that challenge is about culture and cultural elements of that as well. So why don't you ask you, Jason, since some of those barriers to effective HIV prevention in marginalised communities are cultural, how, in your opinion, can these cultural barriers be addressed?
Yeah, the cultural barriers are a big issue, but it's definitely not insurmountable. So I think one thing we can't do is that we can't just directly translate all these very effective campaigns that's been targeted at white Australian men, that's been very effective in the past, and we just do a direct translation into Chinese or Vietnamese. I think that definitely will not work. So what I've learned is that it definitely does take a lot of time trying to cross these cultural barriers. And it's about actually forming messages from the community. So getting them to actually take ownership and build these kind of messages from ground up, rather than us imposing things on them. And recently I've been quite interested in this methodology called crowdsourcing, which basically what it is, it's a bottoms-up approach. So rather than someone up in an ivory tower trying to create these campaigns, it's actually very much bubbling up from the communities themselves. And it's this whole concept of the wisdom of the crowds. So I think just giving credit to these communities, like they do have a lot of strengths, and tapping into those strengths and just asking these communities, these culturally and linguistically diverse communities, to come up with their own messages, their own the phrasing to use, and how do you want to package this? How do you want to deliver it? Coming up with stories, images, videos, those kind of things is super important. And I think someone's already brought up the fact that overseas born men are not a monolith. They're not all the same. And so every culture, every group needs to be nuanced, and you need to listen to every group. So it's not easy, but I think it's possible. And I would end by saying that, to cross the cultural barriers is actually also, it's simple in a sense that we just provide holistic care. I think providing that people-centered care, and I really reinforce what Edwina said. It's about not just about HIV, but it's about the whole person, people-centered care, and treating them as individuals. And I mean, crossing these cultural barriers just means that we just need to reinforce individual self-worth, and also reframing some of the conversations. I think far too much we've talked about, you're at risk for HIV and you are highly risky and these behaviors, but reframing it to one of benefit. These things could benefit you. So giving the autonomy and the agency back to these communities and giving them the tools to carry that forward. I think it's some of the ways we could cross these barriers. Thanks.
Yeah, thanks, Jason. Much more complex than just translating it from English to another language and sort of saying tick the box that the job's done. It requires a bit more nuance than that, for sure. I'm going to jump to a question that's popped up from John Rule at NAPWA, and he's commenting on something you were talking about, Edwina, about the exciting ideas on peer navigators in the research space. I'm going to throw to Graham, because the comment from John goes to you, Graham. It says, Graham might want to comment, but within the HIV peer navigator work, it's been thought of mainly as peer support navigation, but could perhaps be extended or explored. What are your thoughts on that, Graham?
Look, there's actually a long history, both in HIV and a whole lot of other areas, of peer workers being involved directly in a lot of research, a lot of whole range of programs. It hasn't always happened that formally. It's been more sort of individuals people have known who have been really influential or been really passionate, like volunteers of a lot of the peer organisations and community organisations and so on. What I think is really exciting on that one is one of the things that we've picked up with a lot of the work we've been doing with the peer navigator programs is, and that's not even just in HIV, that's across Hep C and a whole range of areas, is the nuance insights that peers have about what's happening for their communities and clients is very different to what gets disclosed to clinicians, gets disclosed to managers in community organisations, gets disclosed to a whole range of others. The relationship there is quite different. And it's very much often if we aren't able to have like Edwina was saying really well, getting different people involved in research. Some of the peer navigators that we've got involved, sorry, one thought I'd got rid of that phone. I'll just throw it over there somewhere. I was going to say is like the nuance and day-to-day current knowledge they have is exactly what we need in research. That day-to-day current knowledge is what makes them such good peer navigators. They understand what's happening to for the people they're working with and solutions and so on. But it's the same knowledge we need within policy, we need within research and so on. And I actually think that's something really quite exciting. And it also provides more opportunities for, I think, for peer navigators to have more influence and be part of the whole response. Yeah, so it's something I think it would be good to formalise rather than just doing on an ad hoc basis that I think we've done for a long time.
Yeah, sure, I agree. To make it the way that research is done in a proper way as a formal part, but of course that's going to cost money, but to some degree. And there's a question in the chat from Anth. I'm going to read it out, but I'm going to throw it kind of open to anyone on the panel who wants to jump in and have their thought on this one. There is not much incentive even for Australian-born people living with HIV to participate in studies. A $25 Woolworths card doesn't mean much. Appealing to altruism is not always enough. We are focused on life's basics, earning a living to pay bills, seeking meaningful relationships, parenting, caring for aging parents, trying to have some fun, enjoyment along the way. Very good point. Thoughts from any of the researchers?
One, look, I'll just throw it in there, and I'm coming from my colleagues would quite agree. I think some of this is around the research sector and the policy sector valuing the expertise of community and peers to the same extent that they'll value other expertise. And I've had a number of success with a couple of universities around through ethics boards and so forth of ensuring that if we've got reference groups and things like that, if we're paying people sitting fees, like I'm not saying full-on sitting fees, but if we're paying GPs $100 to come to a meeting, then everyone on that committee in that meeting gets paid the same amount regardless, because the expertise, the insights are just as valuable and are equal. So that is a movement I think that's pushing ahead. In that sense of actually valuing that insight and that thing, regardless of the circumstances that someone's actually in, their time should be valued appropriately.
Yeah, good point.
I was just going to say, Graham, you reminded me when I first started as a researcher, the only people we paid were doctors. They were the only participants, in fact, and really actually private GPs and public health physicians were always pretty generous with their time, but we were always told you have to. And so on one level, I think we've come a long way, because at least now we are. And ethics committees wouldn't let we were told we weren't allowed to pay participants, and I think we first got in the door with injecting drug users, and now I think ethics, the ethics guidelines have gone, fortunately, full circle, and so they in fact now really ask you to talk about how you're going to respect the expertise of participants. But and I think it is also about, I certainly think, as Graham suggested, the more you're involving people in your research, the more you need to look at ways to that their expertise is reflected in some form of payment. But it's right, money is an issue. Money is always an issue in research. So, it's also how we, I guess, as researchers start to lobby the NHMRC, the ARC, to really allow us to put in budget lines that really allow us to do that. I don't know what others sort of think. But I think that's a real stumbling block. They say they want us to do that, but they continue not really to fund that.
And to be fair, that's something I shared tomorrow, is that the vast majority of when I've been running studies, the vast majority of GPs and clinicians and so forth, and researchers and others who we were able to pay, didn't take it and said, keep it in the study, or don't know, that kind of aspect. That's a common scenario.
Yeah.
And most studies, the reality is most studies that, and I think it'd be similar with the Dwayne and Kit and so forth, just don't have the funds to pay anyone anything. And I think that's the biggest stumbling block. Once we can get through that, then it should be assumed that it will be equitable. But I think there's the disinvestment that's happening generally is making that harder. But I think if we can at least get equity happening.
I like that, Graham, where the altruism is optional in the sense of it's your time, your thoughts, your body if you're doing clinical work and participating. So there should be some kind of remuneration offered. And then it's up to the participant in the process to decide whether they want to do that on a voluntary basis or take up that remuneration.
I think those such great comments people have just made, and it seems like it's I'm sorry James McMahon isn't here to reflect on this as well. Like I'm just not across exactly what the remuneration is in some of the, say, the HIV treatment clinical trials at the moment, but it's almost as though we need to sort of do a call out for people between the ages of 20 and 35. What would they want, and could you have choices, including the choice to not be remunerated? And you go to the ethics committee and say, look, they've got a choice of this, or this. And this is because times have changed. People's lives are so busy. People have 2 or 3 jobs that you really have to go with the times. And if Australia wants to lead the world and continue to lead the world in research, and if we want to end the HIV transmission by 2025 or whenever we decide upon, if it's framed within an emergency sort of setting, this is how you're going to do it. So we probably need more research on what people would think is meaningful to them for remuneration, according to age groups and comorbidities.
Yeah, and I agree. It comes back to the thing we've been touching on in various aspects of the discussion tonight, that people living with HIV are not a homogenous group. It's not like everybody living with HIV is unhealthy or poor or unemployed and therefore needs money to participate. There's a lot of people living with HIV who have very highly well-paid professional careers. So it's all about options and about acknowledging differences between people, but still making options available to people who do need support to be able to access that for their time and energy as well. I can't see any more questions in the chat popping up. Did any of the panelists have any final thoughts that they wanted to throw out to the discussion this evening?
Something I was thinking about was, Chad, was because there was a bunch of those other questions, was I suppose some of the things we're talking about in terms of HIV prevention is a lot of the framing tends to be, is HIV prevention, getting through to communities, is it having the impact, that kind of aspect. And I think some of the things we've talked about today is, is prevention, getting it into communities. And I'd try to, my feeling from the years in health promotion, I'd be pointing to sort of turn that around to some of the things that the other panelists have been saying. Is I'd be saying, have communities been getting the reality of HIV prevention into research, policy, health services, and so forth? Like the comments that Edwina was saying, getting the reality of people's lives into the sort of work that we're actually doing rather than the other way around. And there's certainly, I can come back to that, but there's a whole range of things that I think cuts to sort of some of the challenges I find working in some of the policy areas with some of the work that I've been doing with community organisations and trying to translate into some of the policy things like that Kit was saying before about, how do we get evidence-based approaches? And I think one of the challenges is across research, across community activism, across clinics and everything, is that assumption that we're going to have to keep adapting and evolving with communities, that there's not going to be a point where we've got the answer and we just need to communicate it. And then that will solve it. It is an ongoing, constant change. That's really a frustrating message to get through to policymakers, funders, and so forth. And one of the big things, though, was a lot of the research I've been doing with community and peer programs is advocating to policymakers that if you're funding For example, a program that's run exactly the same way, or a clinic that's run exactly the same way year in, year out with no change, that's not actually a good outcome and the sign of a good program. That's a red flag for a program that isn't adapting, because we know the communities are changing. So how could you possibly be running something year in, year out the same way? And that I think is a key thing with research as well. If we're going to keep doing research with communities, there is no perfect way to do that we can then do forever on. It's about constantly adapting and changing it.
Yeah. I guess adding to that, Graham, I think we have to, I feel sometimes, and I think it's a lot to do with the funding and political environment, we're often a bit afraid to look at our own practices at the moment. You know, the more we're asked to evaluate, and I know you're very involved in evaluation, the more we're asked to show evidence in an environment of the impact of our work, but where it's really for funders to just, you know, it becomes precarious, I guess. But I think we have to somehow get past that and also be really willing to look, all of us, all in our different ways, to look really critically at our practice and what we're doing and what we could do differently, what, you know, what hasn't worked, and not to be afraid of that process. But I say that with the knowledge that I think in some ways the political environment can make us more anxious about really drilling down into what are we doing well, what could we do differently.
I think sometimes it's challenging for service providers, clinicians, researchers to almost want that self-reflection and that true evaluation from an evaluator, perhaps like yourself, Graham, who comes in, or lets community come in and peers come in and challenge the way that things have been running and the way they need to go in the future. But that's what we need to be open to.
Absolutely. And I'm just reflecting right now that I mostly evaluate other programs. I'm trying to work out if I ever actually evaluated one. But yeah, so I'm a bit caught out there.
Oh, I didn't mean us, Graham.
Oh yeah, no, yeah.
Edwina, you look like you were going to say something.
Oh yeah, this is an area I've thought a lot about and would like to consider pursuing quite actively, and that is where does the responsibility of employers and unions, for example, begin and end around the broader health aspects of the people who work with them, let's say. And I mean, I know that we have in the workplace, our employers have obligations to make us safe in the workplace. So we have occupational health and safety things, and we see ads on television about, you know, special ways to lift things and being careful, and I appreciate that. But I mean, we have framing at a federal level of including grants very much embedded in our grant system of public-private partnership around health outcomes, and at its I guess at its perhaps most crude and at times perhaps maybe at times ugliest form, you can have mining companies, Chad, you would know very well, mining companies in PNG who have to take responsibility for the health, including HIV tests and HIV treatment for their patients. So I'm not suggesting, it's a little bit of a dangerous thing to suggest, but because it looks like you're inviting the public sphere or private sphere, and private groups to begin to find their way into the private aspects of their employees' lives. Rather, I'm talking about it more as a civil duty. So let's go not so much to employer, but say something like the AFL. What is the responsibility of the AFL and the NRL to all the young men, especially, who prop them up with betting and attendances and memberships, right? To actually thinking about the broader health and the longevity of those participants in terms of things like sexual health, STIs, sexual health. We talk about domestic, we're talking about violence now. There's some themes coming through around, you know, that those big sort of codes don't endorse violence, et cetera, et cetera, et cetera. Where does that begin and end? And what can we leverage with big employers, Bunnings, AFL, unions? How can we go in collectively And I see Jason's got a comment, and say something like, hey, guess what? We are a high income country. We may be able to be one of the first countries in the world, so, hubris around that, okay, to end HIV transmission. And you have a role to play in it. Do you want to be part of it? And this is how we think you could do it. You start messaging, you start talking. And where do we bring in that sort of private world into messaging and also research? Because I think to get the job done, we're going to have to bring some big people in, big, quote unquote, groups in, and think really differently about how to do this.
Sure, some big thoughts, big thoughts there, Edwina. And Jason, you had some ideas around that?
Yeah, I think it's an interesting thought bubble. So I've been thinking about it from the international students' point of view as well, from the universities and educational institutions, which take so much money from these students, but where do they also should they also have responsibility to protect their students from HIV and STIs and so on? And we also know the health insurance kind of policies that they are kind of forced to take. That's also a huge industry as well. But at the same time, and we've tried to do this as a group in Victoria. We're trying to show international students how to access PrEP and so on by talking to health insurance policies companies. But it's so hard. It's so the information for that is very opaque, and so these people who are taking a lot of money from students don't tell them very easily how can I get HIV testing, how do I access PrEP, and so on. So definitely, I think we need to think more laterally and thinking in new ways of these additional players that needs to play a role. And I've just popped in the chat box. So the Agenda 2025 to show that it is possible for us to end HIV. I mean, Australia is very lucky and probably a lot more well-resourced than a lot of other countries. And so we do have the opportunity to do this. And I think the exciting thing about this Agenda 2025 is that the three major political parties kind of committed to it. So the Labor, Liberal, and Greens. So we need to see the financial backing from their commitment, I guess. But I think it's a step in the right direction.
Yeah, thanks, Jason. I guess it'd been my thoughts would be that if we're ever going to do that jump, now's the time, because I think the COVID pandemic has forced large employers, companies to understand that from a public health perspective, they have both a role to play and that responsibility to, protect the health of their staff and their staff's families, and their health and well-being is not just a requirement by law, which has implications if they don't do that, but actually they have a very important part in that process. I mean, even big companies now, the largest employers in Australia, thinking of rolling out the vaccine themselves to their is an example of where they're starting to step up and understand public health.
Yeah, and it comes back to the issue of power and the role of power, both in our lives. We feel we're lucky we're employed. Well, of course we are lucky, but boy, our employers are lucky that they have us as well. So power has to be, equalized, and it's a change in thinking. It's a change in thinking where you go to a big company and say, do you know how lucky you are? You've got all these remarkable employees, and do you want to have them gainfully employed, etc.? That without them you're nothing. So let's think about their health. It takes courage to tip up the way that we think, because it's habitual the way we think. We all think that way, and I completely agree. Now is the moment. Now is the seize the day. In the next 12 to 18 months, I think you're absolutely right.
For sure. Never before has epidemiology and public health been household terms used on a regular basis. So now's the time to capitalise. There is a question there in the chat, which I think we'll finish off perhaps tonight with, which is a big one, and it's not always an easy one to answer. But it looks at the role of big pharma, who obviously have a lot of money and are big employers and have vested interests in health and in medical research agendas. The question is, do they engage objectively with prevention researchers? Is their engagement objective, or do they have their other agendas, I guess? Question. Graham, you're going to fire away on this one.
Okay, so full disclosure, I receive funds from state governments, Commonwealth government, in a bit of different projects, Vive Healthcare, Gilead, to the spectrum. And all of those funds are, it's somewhat easier for me in many ways because I'm not involved in treatment prescribing. I'm not involved in any of the decisions about treatments and so forth. So the funding that I have access to through pharma, whether or not they should be giving all this money, but some of the funds that I have are quite independent and are called unrestricted funds. So they're independent of the pharma. But what I would say is the word objectively is a really important one. That's different to some of the other things. And I would say that pharma is as objective in their funding as state government and Commonwealth funding. And I mean that with all the nuance and sarcasm that it involves. I've had a lot of challenges of working out when most government funding is also just as political as, there's an agenda behind a whole range of those things. What's important is being able to be clear about the community purpose, reason, and priority for the research that we're doing, and staying focused on that. To me, is what I suppose myself and my colleagues have stuck to ensure that it doesn't become too skewing. But I have easier waters to navigate than if I was a clinician in some of the clinical research.
Yeah, exactly. And it's down to that negotiation, I guess. Kit, I wanted to just throw back to you for a second, because you manage, I guess it's Melbourne's, if not one of the largest in Australia, clinical sort of centres for sexual health that looks after a lot of people who are either at risk of or live with HIV as well, who go there for their services. And I know that your service has been at capacity for a long time in terms of crying out in some regard for an acknowledgement of government and others that you need more to be able to expand to meet the needs and the demands that are upon you. And without a service like yours, where you've got people like Jason who embed research into that work, then we're not going to get a lot of people signing up to clinical trials on HIV, etc. What is it that you think clinical services need at this point in time to be there, to be not so stretched that they can help with the research agenda on sexual health and HIV?
So you're right, we were absolutely at capacity, and there was evidence that the inability of us to meet the demand was creating upward pressure on the prevalence or the amount of infections, most notably syphilis. Our rate, despite having fewer gay men than Sydney, was 50% higher than Sydney, and it was translating into transmission to other groups as well. So that was towards the ends of 2019, and the same is true for HIV, whether it be HIV testing, so you get early diagnosis, early starting treatment, or whether it be access to PrEP. We have a small PrEP service. So at that time, we made the case on multiple occasions to the government that, unlike Sydney with 36 sexual health services, effectively one, albeit the largest, I might say the best, but no, despite that, the largest in the country, we needed more. The government have moved a bit, so they're trying to get a series of general practices around the state to provide services, and good on them for doing that. It's probably, to be old, honest and brave enough to say what I think, a way of trying to see if there's a way to spend less money to provide more services by tapping into the Commonwealth funds. We have been given this reprieve of COVID, I might say. So we've got a little bit of breathing space, and hopefully those GP practices will work to provide more services like PrEP and so forth. But it's a low prestige area to work in. If you look at the prestige of different specialties, ours is last. People look and say, "Oh, who want to do that?" Oh, you go to a dinner party and you say that, and they change the topic immediately to something more palatable. So the governments don't like funding that. They like funding cancer and children's health and all that sort of stuff. I just think it's really important we keep saying two things. The first thing is STIs in a population that includes HIV as well is no longer the fault of the individual in relation to choice. The amount of those infections that occur in a community are almost entirely due to poor government policy. We just have to keep saying that loudly until they finally get it.
And, I've seen you talk on that with syphilis, about syphilis before, and strike that point home that it's not the individual's fault for getting it. It's the fact that the system around them has failed from an epidemiological stance in terms of stopping it being out there in the community. And I think, again, to hark back to the current days, now's the time to capitalise on that message, because people understand that the person who walked into Coles and got COVID when they thought that it was 100% safe and then there was nothing circulating, it's not their fault. They didn't do anything wrong to get it. They went in to buy food for their family. They just happened to, unfortunately.
That's right. And the chance that when you walk to Coles, you got COVID was government decision. It was, Trump and Boris and other people like that compared to the state governments, not the federal government, the state governments and their control of COVID here.
Yeah, I 100% agree with what you're saying. And we just know the evidence is so clear that, even if we go to STIs and HIV, throughout the world, there's cases where people who have lower risk profiles have higher prevalence of HIV because of access to testing, access to, all of these different things. That's the differentiating factor, not the risk behaviour, and the number of times where the risk behaviour is actually lower than those who have easy access to testing, easy access to all the different aspects. And that's government and policy decisions. So I agree. It's one of the challenges I've had around HIV prevention is about policy change and activism. That is clearly at the absolute centre of HIV prevention. It was at the beginning, and it should still be now. Education campaigns are critical part of that, but they're what flows out of that to actually get the sort of changes, to get the clinical services. Just the outrageous advert in New South Wales recently using fear to scare people around COVID and getting vaccinated when we've got an appalling vaccine rollout is just abysmal and harm-inducing.
So just to follow up with that, there's no country in the world that has greater discrepancy almost in healthcare than the US. And African American women have HIV 30 times more commonly than white women in the US. They don't have more sexual partners. They don't use condoms. The HIV is not more transmissible in that population. It's all about HIV testing, access to care, PrEP, getting on treatment, etc. So the point Graham made is absolutely true. Governments have to stand up and say, you know what? It wasn't Bob's fault he got syphilis. It was the government's.
Yeah, exactly. I think we're approaching our time limit for today. To me, the take-home message from hearing from you all is, we've reflected on the past here, and it was about the chronology of research over the decades and how we got to where we got to today. To me, my point that we're summing in here is about capitalising on the timing. I think COVID has brought us to a point in time where hopefully we can not see it as something that's going to distract us from funding and efforts around sexual health or HIV and divert that towards COVID, but it's actually a pivoting point in time when we can use public knowledge and awareness and interest in infectious diseases and epidemiology and public health and government interest in it to seize the day, seize the moment, to get that extra funding, for your clinics, Chris and Jason and others, to expand, to be able to meet the needs for the research that you do, Jeannie and Graham and Edwin, you're all researchers, to actually answer those unanswered questions, and money also to make sure that meaningful participation of those peer navigators, or whatever we call them, are there from the beginning of the research ideas, and the voice of community is heard all the way through. So I want to encourage everyone, I guess, who's listening and coming to join us tonight that, now's the moment, maybe. Now's the time to sort of get out there and plug at the advocacy piece that you've been wanting, or put in that application to the NHMRC or others around that piece of research that you want to do. It might be the time to capitalise on interest. So thank you to everyone for coming tonight and participating. Thank you to our panellists and for your time and your wisdom. And thank you to Thorn Harbour Health again for hosting tonight. Remember, this is just the third in a series of 5 or 6 of these sessions. The next one will be on the 28th of July. And there we will look at the topic of the future of HIV research. So looking at the crystal ball, gazing into what's coming next. So thank you, everybody. Enjoy your evenings wherever you are, whether you're locked down or not, or about to be. Stay safe and have a good evening. Thank you very much.
Thank you, Chad.
Thanks, Chad. It's great. Thanks,
Chad.
everyone.
Excellent. Thank you, other fellow panelists.